Definition of blindness. WHO defines blindness as a visual acuity of less than 3 by 60 as assessed by the Snellen's chart. Snellen's chart can be seen at the right lower corner, or its equivalent. What is equivalent of less than 3 by 60? That is, if you do not have a Snellen's chart, how do you assess whether the person is blind or not? It is the inability to count fingers in daylight at a distance of 3 meters. Hence, 3 by 60 is practically equivalent to counting fingers in daylight at a distance of 3 meters, and similarly 1 by 60 by Snellen's chart is practically equivalent to counting fingers in daylight at a distance of 1 meter. Blindness leads to reduced economic and social status and even premature death. Lower life expectancies have been observed among the blind compared to non-blind people. Categorization of visual impairment by WHO has been done by International Classification of Diseases 10th version, that is ICD-10. WHO classifies visual impairment into no impairment, low vision and blindness. Why is this categorization done? Because people who have no impairment, no visual impairment, may not be eligible for certain benefits, whereas those who have low vision may have some benefits but not as many as those who are blind. So it is important to have a cutoff line for describing those who do not have an impairment, those with low vision and those who can be included in blind. Also, if surveys are done, then the survey people who go around enumerating those who are blind have to have a clear-cut definition as to whom to include in low vision and whom to include as blinds, so that the prevalence of low vision and prevalence of blindness can be accurately calculated. So for having a very practical cut-off lines, WHO has classified according to this. And so no impairment is when the visual acuity is 6 by 18 by Snellen's chart or better than that. Whereas low vision begins with a visual acuity less than 6 by 18 and till 3 by 60. Because below 3 by 60, the person is called blind. With low vision has been further subdivided into moderate visual impairment 6 by 18 to 6 by 60 and severe visual impairment 6 by 60 to 3 by 60. Blindness category 3, 3 by 60 to 1 by 60, category 4, 1 by 60 to just light perception, and blindness category 5, there is not even light perception. Indian definition of blindness. We have seen that WHO has defined blindness at the level of visual acuity of 3 by 60 or its equivalent, which is inability to count fingers at a distance of 3 meters, that is 10 feet. But in India, under the National Program for Control of Blindness, blindness has been defined at a little higher cutoff, which is inability of a person to count fingers from a distance of 6 meters. And the technical definition is a vision of 6 by 60 by Snellen's chart or lesser with the best possible spectacle correction. Problem statement, the world status. According to 2010 data, 90% of the world's blind are living in developing countries. And 80% of this blindness is avoidable. That is either treatable or preventable. We will talk about avoidable blindness a little later. 82% of the visually impaired are 50 years or above. Otherwise, this age group forms just 20% of the population. But 82% of the visually impaired are in this age group, which means that as the world's elderly population percentage will increase, there is a need to increase measures for controlling blindness. Most of the visually impaired children are visually impaired because of refractory errors, which are easily correctable. That is, they are unnecessarily visually impaired. But overall, visual impairment in the world has decreased since 1990s, mostly due to public health action. That is, due to vitamin A deficiency control, so that kind of blindness could be prevented, control of infectious diseases like trachoma. Hence, more due to public health action, the blindness level in the world has reduced since 1990. Problem statement in India. The estimated prevalence of blindness in India is 11.2 per 1,000 population, slightly lower in men and higher in women. This is the age group wise prevalence of blindness. The 0 to 14 years is 0.1 per 1,000, 15 to 49 years 0.6 per 1,000, and C, more than 15 years of age, this age group has a dramatically high prevalence of blindness as 77.3 per 1,000 population. The last survey was held in 2006 and 7, and it showed that the prevalence had reduced from 1.1% to 1%, and that the estimated national prevalence of childhood blindness and low vision was 0.8 per 1,000 population. What are the major causes of blindness in the world? You can see cataract forms a major 33%. That is, 33% of the blind in the world are due to cataract. Others are glaucoma, uncorrected refractive errors. The number of visually impaired from infectious diseases has greatly reduced in last 20 years, as discussed before, because of public health measures. Those were causes of blindness in the world. Causes of blindness in developed countries. In developed countries, accidents is the number one cause. Others are glaucoma, diabetes, vascular diseases like hypertension, cataract comes way below, degeneration of ocular tissues, and hereditary conditions. The causes of blindness in Southeast Asian region of WHO. Cataract still accounts as a cause for a major chunk of blindness. 50 to 80% of blind are blind due to cataract. Others are uncorrected refractive errors. Vitamin A deficiency. This used to be a major cause of childhood blindness, but now it has declined to very low levels. And as the other causes which are treatable or preventable are decreasing, the emerging causes are glaucoma, age-related macular degeneration, diabetic retinopathy, corneal ulcer, and ocular trauma. Corneal opacity originally used to be more due to xerophthalmia, advanced vitamin A deficiency, and trachoma. But now, as these conditions are controlled, the corneal opacity is, the reason for corneal opacity is now more is because of trauma and corneal ulcers. Now, what are the causes of blindness, major causes of blindness in India? You can see that cataract still forms a huge chunk of around 63% of the blind. That is, 63% of the blind are blind due to cataract. Also, senile cataract occurs a decade earlier in Indians compared to their Western counterparts. Other reasons are uncorrected refractive errors, glaucoma, posterior segment pathology, and others, which include injuries, congenital diseases of the eye, retinal detachment, tumors, hypertension, diabetes, leprosy, etc. Epidemiological determinants of blindness, that is the risk factors which increase the chances of blindness. Age. It is seen that 30% of the blinds lose their sight below 20 years of age. The causes in the younger age group are refractive error, trachoma, conjunctivitis, malnutrition, mostly vitamin A deficiency, and in middle age, the causes of blindness major is cataract, refractive error, glaucoma, diabetes mellitus. Other risk factors: sex. we have seen that there is a higher prevalence of blindness in females. This is because of higher prevalence of trachoma, conjunctivitis and cataract among females. Malnutrition. Malnutrition increases the chances of becoming blind. Mostly vitamin A deficiency. Measles and diarrhea, they precipitate malnutrition and thereby precipitate acute vitamin A deficiency. Protein allergy malnutrition is associated with vitamin A deficiency, and hence malnutrition as such is associated with blindness. This malnutrition related blindness is limited to first 4 to 6 years of life. Occupation. Certain factories and cottage industries where eye injury is possible, like welding, stone crushing, etc. Social class. Blindness is twice more prevalent in poorer classes. Social factors. Indulging in treatment with quacks, ignorance, poverty, lower levels of hygiene, and living in an area with inadequate health services. They are all risk factors for blindness. Blindness control. With so many diseases to control, why should we prioritize control of blindness? Because blindness is a significant burden to the society. Why? Because it leads to significant loss of productivity and hence the cost of lost productivity. And the cost of rehabilitating the blind is very high, and that of education of the blind are very high. On the other hand, swift and effective use of resources for prevention of such blindness is very small fraction of above cost. And hence, it is very cost effective to control blindness, control and prevent blindness in terms of resources and human suffering avoided. Changing the concepts of blindness control have changed over time in a way that there is now more emphasis on comprehensive eye health care for control of blindness. That is avoidable blindness. As we can see, a large chunk of blind is avoidable blindness, that is could have been prevented, for example vitamin A deficiency, or can be easily treated like cataract and refractive errors, instead of management by clinical ophthalmologist alone. That is as was previously practiced. When the blind presents himself to the clinical ophthalmologist, he or she would treat accordingly. But the emphasis now is on comprehensive eye health care, that is preventive, curative and rehabilitative care of the eye. If vitamin A deficiency is preventive altogether, as it is now prevented to a large extent, a big chunk of blindness is prevented only. Also, trachoma has been controlled, which prevents blindness because of the complications of trachoma. The complications of trachoma, if they are detected early and treated, is again a prevention of blindness. So the emphasis is on comprehensive eye health care, that is preventive, curative and then rehabilitative. Let us discuss in little more detail what is comprehensive eye health care. Comprehensive eye health care includes the following concepts. Primary eye care, that is inclusion of eye care in the primary healthcare system itself. Promotion, prevention and management of common eye diseases can itself lead to a lot of prevention of blindness. Then epidemiological approach, that is measurement of incidence and prevalence and risk factors, as we discussed before, of blindness. Unless we know the incidence, prevalence and the causes and risk factors for blindness, we cannot work towards its control. So we have to measure the amount of blindness first and then work towards its control. So actions would be based on these. Team approach, that is, it's not just the ophthalmologist who will treat the blind, it will never lead to control. Involvement of auxiliary health workers like ANMs, multipurpose workers, ASHAs, who are really instrumental in giving the primary eye care, have a lot of role in prevention of blindness. And establishments of national programs, because as we discussed before, blindness is a lot of burden on the society, and hence establishments of national programs for control of blindness. Initially, our country had programs for control of trachoma, which was later merged into national program for control of blindness. the concept of avoidable blindness. A major portion of blindness in developing countries can either be cured or could have been prevented. An example of curable blindness is cataract, and blindness that could have been prevented, example are vitamin A deficiency. Protein energy malnutrition is associated with vitamin A deficiency. Measles, diarrhea and severe pneumonia can precipitate a pre-existing vitamin A deficiency into severe vitamin A deficiency, which can lead to blindness. Trachoma and its complications. If trachoma is prevented by simple hand washing, face washing, or treated by antibiotic treatment, or its complications treated early by corrective lid surgery, can all prevent corneal blindness. So this is an example of preventable blindness. Avoidable blindness hence is seen in areas which are underserved and have general lack of eye health services. Early treatment of infectious diseases of the eye and nutritional eye disease is essential to prevent visual loss. And moreover, such treatment can often be delivered effectively by peripheral health worker level itself. It does not require an ophthalmologist or even a doctor or even a nurse to administer antibiotic ointment for trachoma treatment or to give vitamin A drops. What are the causes of childhood blindness? Childhood blindness is blindness among less than 16 years of age. These are xerophthalmia, that is dry eye due to vitamin A deficiency, the severe form of which can lead to blindness. This is now considerably reduced because of vitamin A supplementation. Congenital cataract, congenital glaucoma, optic atrophy due to meningitis, retinopathy of prematurity, and uncorrected refractive errors. This slide shows photographs of severe deficiency of vitamin A resulting into keratomalacia followed by corneal opacities leading to blindness. Now, preventing and control of avoidable blindness. The control of avoidable blindness in any given population, the first step is initial assessment of the prevalence of blindness and various causes of this blindness, and to see if avoidable blindness forms a considerable chunk to be controlled. According to this, we can set priorities and appropriate measures to control the major causes of avoidable blindness, followed by intervention for controlling avoidable blindness, which consists of primary eye care, secondary eye care, tertiary eye care. We will discuss these in a little more detail in the following slides. We can also launch specific programs like India launched Trachoma Control Program in 1963, which is now merged with the National Program for Control of Blindness. School health services, especially for detecting refractive errors and communicable eye diseases. Vitamin A prophylaxis, occupational eye health services can be launched. In addition, long-term measures will lead to decrease in prevalence of blindness, like in general improvement of quality of life, improving sanitation, water supply, and better food intake, especially foods rich in vitamin A by the population. All these are to be followed by evaluation after some times the efforts have been running in the population. Now, these are the steps in any planning cycle for controlling any disease. Hence, here we will discuss in detail about the interventions specific to eye health, that is primary eye care, secondary eye care, and tertiary eye care. Primary health care, that is conditions which can be easily recognized and treated by the primary healthcare worker himself, like the ANMs or ASHA worker. Acute conjunctivitis, ophthalmia neonatorum, trachoma, trichiasis, entropion. Can be seen that trachoma leads to malformation of the eyelids, which can lead to eyelashes being misdirected and rubbing against the cornea. Chronic irritation of the cornea with these eyelashes can lead to corneal opacity. Some conjunctival, subconjunctival hemorrhages can be recognized by primary healthcare worker and to some extent watched, observed. Conjunctival foreign body removal, corneal foreign body removal or referral to high. Night blindness, pyroid spot. Treatment is oral vitamin A or 2 lakh units on 2 consecutive days. Lid lesions like stye, chalazion, allergic conjunctivitis, etc. This is a list of drugs that can be safely made available to the primary level healthcare worker. Conditions which should be recognized by the primary health worker and immediately referred to secondary eye level care. Not to be treated by them but to be referred to a higher level of eye care include corneal ulcers. The presenting features are red painful eye, reduced vision, intense watering of eye, frequently result in corneal opacity if it is not treated in time. The diseases which need to be referred to the secondary level eye health care also include perforation of the eyeball, late lacerations, entropion, trichiasis, cataract, pterygium, visual loss, burns of the eye including chemical burns, lid lacerations, etc. The secondary level eye care services include the services available at the secondary level include definitive management of common blinding conditions like treatment of cataract, surgical correction of trichiasis and entropion, ocular trauma management, management of glaucoma, etc. Secondary level care is provided by primary health centers and district hospitals if eye clinics have been established in these. Secondary level eye care to some extent is also provided by mobile eye clinics. These majorly perform cataract operation because it is a major cause of blindness. They also are used for conduction of surveys regarding the prevalence of blindness and the major causes of blindness. This requires a lot of community participation and leads to effective use of resources as it is problem area specific. But adequate follow-up and evaluation of those treated is a must. So it is useful, but because it lacks permanence, there is some limitation in its use. The tertiary level eye health care is provided by the regional capitals and often associated with medical college and medical institutes. These provide sophisticated surgeries like treatment for retinal detachment, corneal grafting, etc. These often have an established eye banks for corneal grafting, etc. Tertiary level eye care services also include rehabilitation of the blind. For example, special schools for the blind. An example is National Institute for Blind in Dehradun. National and international agencies involved in the work in preventing blindness. The National Association for the Blind is a voluntary organization and provides welfare services to the blind throughout the country. Royal Commonwealth Society for the Blind also works for the same end. WHO invited the national and international agencies to combine to form an international agency for the prevention of blindness. The main area for this agency is prevention of blindness, and activities include exchange of workers, of plans, enrich each other's blindness control programs, etc. Vision 2020 Right to Sight is a global initiative by WHO. It was launched in 1999 with an aim to eliminate the avoidable blindness. It recognizes sight as a fundamental human right, and the major causes that it aims to prevent or cure are cataract, xerophthalmia, refractive error, trachoma and other causes of corneal blindness. This is the infrastructure envisaged under the Vision 2020 initiative. This is discussed in a little more detail in the lecture on National Program for Control of Blindness. Here it suffices to say that there is an aim to establish 20,000 primary level vision centers which will give primary eye care, and 2,000 service centers which will provide secondary level eye care, and to establish 200 training centers and 20 centers of excellence in each country which will provide tertiary level eye care, and also conduct surveys, provide trainings and laid out standards, etc.